All right, so why don't we get started? And thank you for attending. We have a couple people, it's like 2 or 3 people or so online, and a couple people here in person. We're going to slightly talk about a different topic than what we talked about at the first time. So the first one, we talked a little bit about some of the quality metrics that we want to go through. And this one, I want to do a couple things. I want to talk about the structure of our schedule. And then since we have a small group, I'll talk a little bit about some of the vaccine data that's come out from the New England Journal, actually just this month, and, as well as a few kind of future topics for us at the Medical Center. So one of the things that we try to do is, Allison and I try to be very data-driven about how we want to approach this. And so one of the things that we've done is we've looked at the utilization of the Medical Center over the past 2 years. And we look at both how many same-day appointments are necessary, how many people call for same-day appointments, how many urgent care type appointments we get, how many emergencies we get, et cetera. And then build that, extrapolate how much utilization we're going to need to anticipate, and then build that into our schedule. So we build in 6 same-day slots every single day, June, July, and August, because that's what the data has been telling us in the last 2 years, that every day it's roughly the demand on the Medical Center. So what we're trying to do is, how do we build a system that allows us to maintain our primary care practice with our urgent care or same-day needs, as well as some emergency bandwidth? And if somebody has called, if you can kind of build off of some of the conversation that happened with the last community chat, is that if you've called the office and the clinical team is giving you an indication that we're going to take your name and we're going to triage where you can have your best experience, it's because you've exceeded those 6 slots. You were number 7, number 8, number 9. So we anticipated 6, but if we get 7, 8, and 9, then we have to find a place to put that individual so we can meet their needs in the best way possible. Some people may look at it and say, I can't get an appointment, but the answer is that's not really accurate. The first 6 get slots, but you're now in excess of those daily slot allotments. And then triaging is kind of what is our next line of defense. So we've built in the 6 slots historically. If you're in that 7, 8, 9, et cetera, then what we do is we apply clinical decision making. So now the clinical team, not the front desk staff, so that's another area where there can be some confusion. Only the nurse, myself, or Lori will be making the decisions on where this individual needs to be based on their medical necessity, not the front desk staff. And then we offer them the most appropriate spot so we can ensure really high quality service for that individual. And we need to also maintain that same scheduling for those people that have chronic diseases. So our commitment, obviously, to the island community, our island community, is if we want to provide primary care and chronic disease management, we need to maintain that bandwidth 12 months a year. But we understand our obligation and our needs when it comes to same-day appointments that happen in the higher months. And then when it comes to emergencies, we can also anticipate to the best of our ability. So the last 2 years of data have really kind of borne out that we average about 4 emergencies. It shifts a little bit. We get 3 in June, 4 in July, and 6 in August per day. So then I just averaged them out and said 4. So we anticipate that we're going to get 4 911 type of calls per day that we need to also find a way to fit them into our overall schedule. And one of the neat things that we tried last year, and we're going to keep building off of it, is when we do get 911 events, in order to help that individual that has a more serious health-related issue and not completely disrupt everybody who had a regular scheduled appointment that doesn't necessarily have to be addressed right now, we apply this yellow-red designation, which allows the front staff to execute a work plan, excuse me, that will then say, if it's a red, please cancel all the rest of the appointments. We have somebody in cardiac arrest. We have somebody with a major trauma. And I don't want those people sitting in rooms. They don't need to hear what's happening. They don't need to see what's happening. We'll fit them in over the next couple of days. And if it's yellow, it's kind of like, just put your foot on the brakes. Can we just slow down a little bit, make sure we're maybe that 7th or 8th same day appointment, we might not be able to accommodate right now because we are tied up in this trauma room for the next hour, hour and a half or so. And we just want to try to be respectful of people's times, because I've always been very concerned about flow. One of the things that we talk with the students a lot about is flow. I don't want people to feel like every single time they have an appointment that that's a 45 minute to an hour appointment. I don't want that. It's appropriate when we're doing physicals. We spend a lot of time. But if you're coming for a tick issue, it shouldn't be an hour. So flow is important. Your time is important. And then one of the things that we're really venturing into is that we're trying to ensure these high quality outcomes. So this summer, we're upgrading our x-rays to a digital x-ray. Over the last several years, the health center has been unable to align ourselves with any assistance from radiology off island because the mechanisms of our x-rays are so poor now that they don't want to be responsible to try to give an opinion on an image that's fuzzy, let's say. And so thanks to the Russo Foundation, we're going to be upgrading to a digital platform in June. So that way we'll have high quality diagnostic images that Lori and I can use to not only make a diagnosis, but then we can align ourselves with outside radiologic groups that can say, hey, this is a difficult read for us. Could you give us an opinion on that? And we can transmit it electronically to them. So that's really a wonderful upgrade for us. And the quality is to allow the proper slots to discuss your needs. This is that physical. This is that diabetes visit. Our first year together, Lori and I here, I think it was all too common to be in a physical for 12 minutes and then the radio go off. And then all of a sudden, a person that had a pre-designated time to talk about a variety of healthcare related issues, and it could be things from colon cancer screenings to diabetes, we had to abruptly cut short because of the issues that we all know very well. And we felt like that was very disrespectful to the person that was here trying to do preventative care, which is why we don't do elective physicals in the summer now. And that's not unprecedented. We used to do that in the past. I think more when like Paul Mann was here and Dr. Miller, then there was a period where we were doing it, but we just feel like it's in the best interest of the patient to have the time to have the right conversation at the right time about their medical needs without feeling rushed. And then also, I talked about, we need to know the slots. We need to know the 6 slots for the same days. We need to know the 3 to 4 slots for the emergency. So we know how to build our schedule so we can accommodate our year-round population as well as what happens during the high months. So this is just a springboard to have a bit of a conversation. That's my last slide here. I want to pivot to, and I'll get this out in other, you're hearing this first from me, but I'm going to get this out in our other platforms. But we fortunately, this month had, this is actually hot off the press as of today. New England Journal published several articles about vaccines. So I've been getting some questions about how about the 4th vaccine, et cetera, and I'll just read you some excerpts. So this is an original article from the New England Journal about the effect of early treatment with ivermectin, which sometimes comes up as a question. We also have an article about the efficacy of a 4th dose for the mRNA vaccines, which is Pfizer and Mrna, which is what we had primarily here. And let me read you what it says here, that our data provide evidence that the 4th dose of mRNA vaccine is immunogenic, safe, and somewhat efficacious, primarily against symptomatic disease. A comparison of the initial response to the 4th dose compared to the peak response to a 3rd dose did not show substantial differences in humoral response or in levels of Omicron-specific neutralizing antibodies. This article continues to go on and say that there's not a lot of evidence to support a 4th dose. And some of the articles also written in the New England Journal are starting to speculate whether or not this is a wise scientific thing for us to do to our bodies that are not supposed to constantly be in these B-cell modes where we might get exposed, like you get a yearly flu shot, that's one thing, you get a tetanus shot every 7 or 10 years. But to constantly be stimulating the immune system in a way that wasn't developed to do is causing them some concern overall. So the 4th vaccine of healthy young healthcare workers may only have marginal benefits, and older and vulnerable populations were not assessed. So where I think I'm coming down on this is we talk a lot about antibody response to COVID, and that's great. It definitely will go up about 9-fold for about 6 to 8 weeks. And then we're back to our humoral immunity, our T cell immunity that we're built to have. That's the kind of vaccines that we had as a kid, or if you had measles when you were a kid, or measles vaccines. These are the type of processes that our bodies lean on to have good, quick response if we get re-exposed. So it also in this article talked about nearly everybody who had a fourth dose had symptomatic reactions to it, mild. But I think what we consider mild, what the medical system considers mild, and what the vaccine companies considered mild are three different things. But everybody kind of had some type of symptom. So if you were somebody that felt pretty awful after some of the shots, you would likely expect that again in the fourth shot. And there's not significantly huge evidence to really support that you're in a better situation. I think for us, we have a high vaccinated population here. I think we're all pretty smart about how we manage things. And the statistics are, for people that like data, the moment you had vaccination or had been sick with COVID, you have a 0.7% chance of being hospitalized after that. And if you got a booster shot, it went all the way down to 0.3%. So the numbers are staggeringly good that one person in 300 to 333,000 people would go to the hospital if you've been immunized. So I think if you've had your 2 shots of Johnson & Johnson and a booster, or you've had 2 Mrna plus your booster, or you've had your shots and then had an infection, the data is pretty compelling that you're doing really well. You're doing really well. I do agree that for people that are severely immunocompromised or have real frailty, it's probably a smart thing to get them kind of hyper vaccinated for a 6 to 12 week period of time. But then after that, their immunity is going to fall just like the rest of us. They also made comments about protection against children. And they had kind of similar scenarios with vaccinations when it came to the children. And then ivermectin, which was a treatment for COVID originally, was also commented finally on a quality study. It always had a lot of like World Health Organization studies, but never really a well done study as we would typically expect in the United States. And the effect overall was that, quote, treatment with ivermectin did not result in lower incidence of medical admissions to the hospital due to progression of COVID or a prolonged emergency department observations among outpatients with an early diagnosis of COVID. So ivermectin is not a viable treatment. And this is an area that's rapidly changing. Pavlovid is the only one that really we would use now. So the other one that we have at the office is now become defunct as well. So it's rapidly changing the monoclonal antibody scenario. So Paxlovid is what we have, the tablet. We'd have to get it from the pharmacy at CVS. They're the only ones that really have it in the area. And then lastly, before comments, just a kind of a synopsis for us. We've provided 12,540 visits in the last 2 years, which is terrific. We also support behavioral health, physical therapy, dentistry, massage infrastructure. We've partnered with South County Health to enhance the community services with a dedicated home health nurse and hospice services. We've partnered with Rhode Island Primary Care Physicians Corporation and the ACO Integra to bring a more modern approach to our comprehensive healthcare services. We want to focus on quality metrics and practice cultures that have proven to improve patient outcomes and hopefully put us on a sustainable financial course. And this helps us kind of join the national efforts to improve patient outcomes while being able to participate in these more modern financial situations. What we want to do in the future is we're looking to bring some specialists to the island. We were able to pull from our data. We know where our specialist referrals go. We know cardiology is a huge referral for us, pulmonology, podiatry, all these things. We know where our numbers are. So that allows us to better target some specialists like cardiology that is completely employed by South County Health nowadays that probably come on out. We've had a conversation with the CEO of South County Health to see if we can partner in these ways. Maybe they can send out a cardiologist once a month. And for many of the individuals that see these cardiologists, it'll save them a lot of time and energy and resources to have to leave the island to go see them. We also want to continue to work with fire and rescue to really have a fully comprehensive process here on the island and to meet kind of our needs, kind of the unique needs of the island. But so we've done a lot, we've got a lot to do. And I'm looking forward to any comments from the listeners online and any comments from King Keith Lewis.
I always let her speak first.
Smart, you're a good man.
Smart man, yeah. I think the head of the CDC said, like yesterday or today, that a fourth dose was recommended for people over 70 or something like
Correct.
that. What did the studies say about that for the official elderly?
I think this is an area in medicine where, and I had some conversations with colleagues about this, I think the politics are running into the science a little bit, and where is it true that the average 70-year-old would benefit from immunization? By all means, yes. But I think it's more of an individualized conversation with their healthcare provider. Again, I think if you're frail, or I think if you're in a scenario where you're constantly exposed, or you have some type of medical condition that makes you extremely vulnerable, then I think it's a wise choice. But I think if you're a healthy, active 70-year-old person that takes good care of what they are exposed to and how they manage their life, then I think it's really a very personal decision. And you'll notice that Dr. Walensky had to walk it back a little bit, because when she made that statement, she then had to kind of clarify what she meant, because she knew that she didn't have data to really support that everybody should get a fourth dose. So then it was anybody over, let's say 50, consider it. Then it became anybody over 70. And so I think you're seeing, if you kind of read between the lines, they're trying to give good public health guidance, but there isn't the push like they originally had. If we knew then what we know now, they probably would have done a two-dose series much further apart from each other. But obviously Omicron and Delta was spreading rapidly. We were doing everything we can to protect people, but they probably would have said, here's a shot, and then here's another one, say 16 or 20 weeks later, which is why you saw originally that Mrna had a little bit better effectiveness against Delta than the Pfizer product, because the Pfizer product had a shorter interval between their vaccination dosages than Mrna. So then it kind of brought in the light that we probably should have spread them out, but everybody did what the science was telling them at the time. But now that we know more, I can say that for a healthy 70-year-old, it's a very viable option, but don't feel compelled. Make it a personal choice.
And what about infection rates? I looked online last night or the night before, and there clearly was a little boost in Rhode Island,
mm-hmm.
but I guess I'm interested, what do you see here, and how good are the data these days when so many people are doing home tests and probably not reporting?
Clearly, there's no accurate reporting given how much or how ubiquitous home testing is. There's no possible way people are identifying with the state databases. What I think as a physician, what I look for is that when you look at that rate per 100,000, if you look to the Rhode Island DOH COVID data site, if you go right underneath it, it says hospitalizations. So hospitalizations were 43 last week, and now it's 34 or 33 this week. So rates are up a little bit, but hospitalization rates are down. So I think the way to categorize it nowadays, and I think if the government had to do it over again, they would say, this doesn't prevent you from ever getting COVID, but it prevents you from either being hospitalized or dying from COVID. So people can continue to get positivities, but as long as it doesn't create into hospitalized illness, then I think that's a success of the vaccine overall. And I think that legacy framing felt like, well, then it's a failure if I'm getting COVID at all. But that was the original public message, and it was probably inaccurate if they had to do it over again. What we've seen on the island is we had at least 4 last week. Okay, we had at least 4 positives last week. And again, very isolated cases. We're going to see them probably ongoingly until we have all the windows open and the sun shining a little bit brighter. I expect that after the April vacation for the school, we'll have another little surge, and the island community tends to disperse when there's vacations. And when you're on vacation, you eat differently, you act differently, and I don't think people are as cautious. And when they come back, we'll test. But we have hugely positive, hugely high penetrance of vaccinations here. So then what we do is typically wait that 1 to 2 weeks after the vacation, and you'll know what's going to happen within that period of time. And I think you'll see that we'll probably get a few spots. And right now what we get is one person directly infects another person and then affects 2 or 3 other people. So it's not like they're random people, it's their pockets. And you can draw the straight line with how they got it from each other. So overall, pretty quiet, pretty quiet. I think it would be unrealistic for us to think that it would be 0 all the time, but they're identified quickly, they're isolated as necessary, and the vaccines work. Sure.
Well, I just want to thank the 2 of you and Tom Hogan as well for what you did for me the past 3 months. When I left the building the other day after the people behind the desk announced that I had graduated. And when I walked out to the car, I was feeling so good. And I remembered how I had felt when I walked in 3 months earlier, when I was in a lot of pain. I think that cure happened on Block Island because of you folks. And you know, I'm very grateful for that.
Well, we appreciate that. I think Lori and I feel very strongly that it's those kind of care interactions and interventions we want to preserve even through our high months. So I know that we've certainly heard a lot of information that there are differences of opinions, you know, that like, are we here for just episodic needs? Are we here for primary care? I think Lori and I feel very strongly that we are here for the longitudinal relationships with island patients to build their primary care, prevent diseases that are manageable that way, in a way that is encompassing of a full-scale comprehensive plan, visiting nurses, paramedicine in the future, to really put a really terrific health safety net on the island, which we have the ability to do because of our geographic isolation, and then work with partners on the mainland for the necessary things that we need. I don't think we find it acceptable to be just an urgent care. I don't find it professionally rewarding. I think it's short-sighted. It's an aspect of the care that we deliver on the island, but it shouldn't be what dominates us.
And then the other day I was talking to a contractor here, you know, with that working age, and he had received wonders from you folks as far as his problem with the skeleton. And one of the things that really made him feel good was the fact that he didn't have to go back and forth to the mainland to a therapist. Not only was it the time issue, but the money issue. And so that made a difference for him.
One of the things that I learned early in my administrative kind of training was that the cost of healthcare on Block Island is different than someone on the mainland. You know, think about that individual. He has to take the entire day off of work. So he loses all of that revenue. Plus he has to pay to get on the ferry. Plus he has to have the vehicle on the other side, or however he gets where he is. So that person, what it costs them to go receive healthcare that day is very different than somebody who lives right adjacent to where their medical community is, and they only took an hour or 2 out of work. The cost of that person's healthcare can be very different, and it shouldn't be so onerous for the island community, and it doesn't have to be if you build the right structure. So I think Lori and I feel that, and Allison as well, we're building it. We're human, we're not perfect. We just want to hear constructive advice about what kind of things people need. I think PT is one of those constructive things that we've heard. It's a tremendous value to the island. We have a lot of musculoskeletal injuries on the island. It's the #1 typical diagnosis that a hospital or an office will get. We have our own physical therapist. That's a real pleasure for us to have that. And to be able to talk with them and help kind of decide problem solving is even better.
So when I was talking to this guy the other day, I told him about this community chat that you have. And I suggested, why don't you go to that just so you can say thank you? And so he's not here, you know. And
you did it for him. We appreciate it.
But it would have been nice for you to hear it.
Thank you.
From him as well. And I think that that's a problem, is you don't get a lot of the thanks that you deserve.
I'm interested in definitely getting the word out to people in a way they'll consume it, right? Where I think we've had a chat, probably a total of 9 or 10 people. And, you know, we hope that those 9 or 10 people will be our ambassadors to other people on the island. But hopefully there'll be a time where there's 20 people in this room that can hear us and understand where we want to be and where we want to go. We'll get there.
One of the great things for me as a patient was and also as an engineer, was learning about the wiring of the human body, the nerves, how a problem up here transfers through the wiring. And so for me, it was not only a medical cure, but it was a learning experience.
That's why the orthopedic surgeons say we're just carpenters in a different uniform in a lot of ways. Yeah. What are your thoughts, Lori?
I was thinking about how great it is that we have physical therapy at the office, but today I had the opportunity to talk to an elderly person in the community who would have difficulty accessing PT at the medical center because it's difficult in her condition to get out of the house. And so it was great to be able to say to her and her husband, well, I can send the physical therapy to you, because now with our relationship with home care, Southern Home Care, we have a physical therapist to see people at home. So we're building out the structure where you can come to us or we have to go to you, which is great. And to your thoughts about hearing people's thanks, to tell you the truth, I mean, I made a very intentional decision to come to Block Island and go back to work in primary care because I love it, because I love the longitudinal relationships that you get with people. And it's a lot of thanks for me just to be in the room with somebody and have them say, this really helped. I feel better. You listened to me. I appreciate that you understand where I'm coming from. All of that feels very good moment to moment every day. So while it's lovely that you come and tell us that something worked for you, we get a lot of it in the exam room all the time. And it's very good way to be able to make people feel well.
Absolutely.
Well, that's one of the points that I made to this particular person. One of the great things about the care that we receive from you folks is that we feel that you really do care about us as an individual. And I'm sure they do on the mainland too, but there you feel more like you're on an assembly line because of that.
There's an expression, I don't know who it's attributable to, but it is that people don't care how much you know until they know how much you care.
Yeah, Oliver Wendell Holmes.
Yeah.
Yep. Yeah. And I think it's so true. I didn't really feel that at 29 when I came out of residency, but I feel it as I've gotten older in medicine. I used to have this in residency when you're younger, then you think about some of these older practitioners, which Lori and I have now become these older practitioners, where they're like, we had a cure for this, so we have a way to fix this. And then, they'd come in and talk to their patient that they'd known for 30 years, and they would say, hey, listen, Kay talked about this. She doesn't want that valve replaced. And how it fits into their lives. And I always felt like those old timers were like an impediment, like that medicine would pass them by. But I think now the beauty was that they have a relationship with somebody. They say, listen, I can be a voice for you. I can try to help be a liaison with what medicine can be and how fragmented it can be, even though we try to make it better. But try to put it in perspective of, is this what you wanted? Is this really how you wanted it to be? Let's talk about quality of life after. Let's talk about surgical, what your recovery would be. Let's talk about all these things. And I think if you don't have that relationship of trust with a provider, where do you get that information? You can't get it from WebMD. You can't get it from the internet. You got to have a personal relationship with somebody. So I think in primary care affords you that for sure.
Well, that relationship that you folks have built over the years with specialists on the mainland. I think I told you already that Dr. Weisbord, who's my cardiologist, speaks very highly of both of you. And to me, as a patient, that's comforting to me to hear that.
I appreciate that. Yeah. Aaron came on a few years after I started at UNC at South County, and as well as when Lori started as a practitioner. But yeah, it's great to build those relationships. I think it helps us with the island community getting access, but then again, building the relationship with certain specialists that understand, quote unquote, the Block Island effect and understand what kind of synergy they have with us. If they need a med titration, what's available. Is there a pharmacy on the island? Is there not a pharmacy on the island? You need people to understand the uniqueness of the island a little bit. And South County's been a really good partner on that. And some people in Westerly as well, but it's been a nice relationship to really bring back. And it was much better here than it was at UNC. There was the big machine, the big academic machine. thousands of physicians. Nobody really knew each other, but to come back and get texts from the cardiologist and the neurologist and other people saying, hey, welcome back. It's more of a family.
Well, I think also, I've noticed also that in getting through my annual physicals with him and through his getting to know me better, I find that he cares about me now more as a person than the first time I walked.
Yeah, he knows Keith Lewis. Yeah, absolutely. How about anybody on the line? I see Naomi is on the line. I see, looks like that might be Jim Himthorne there.
Yeah, Dr. Warcup, it's Jim. Can you hear me?
I can hear you.
Yeah, I would just mirror what Keith had to say. And Lori referred me to Hoban, I don't know, maybe a couple months ago. Lori, I can't remember. Time flies so fast or goes so slow. But he certainly was a big help to me with a back problem. I just need to be disciplined about doing what he says I'm supposed to do. I get a little lazy, suffering from ADD. Maybe you guys could address that the next time I'm in, but I just can't seem to stay with the exercise program. But it's nice to have him there and be available. So we, the Hinthorne family, Pam is here as well, would mirror everything that that Keith had to say in terms of appreciating the fact that you're here. Pam, you want to say anything?
How about the 80-year-olds?
Oh, Pam says, how about the 80-year-olds on the vaccination since she just had that birthday in February? What do you think about
I think it's fine. I think probably 70 and older. If you want to have definitely increased antibodies, I think the fourth vaccine is great. You definitely want to do either Mrna or Pfizer. And then after that, I would probably hang tight. I don't think you need to worry about a fifth vaccine because at this point, the sun will be shining, people will be outdoors, ventilation will be much better. And your humoral immunity or that background immunity is going to be working quite well.
Yeah, so you're saying since Keith and I are over 70 plus that we probably should go off the CVS. Is that what you're saying? You did say it was an individual choice.
I can say that it's an individual choice. I think if you have any medical problems like diabetes, emphysema, it's an absolute good choice. And right now, the state is still trying to work out what's next for testing as well as vaccination because the government just authorized, I think, an additional 10 billion 2 days ago for COVID response, and whether or not that trickles to the state in time. But we will not have vaccination quickly, vaccinations for quickly. So I would say if you can hop off the island, I would do so.
Yeah. Okay. Thank you. Appreciate it.
I got a question.
Bill is now hung up in the Senate. It hasn't passed yet.
So the House must have passed it, but not the Senate. I got you.
So, you know, we don't know when we're going to get that money.
Okay. Yes, Ms. Benedict.
I got a question. Yeah,
Yes,
I'm your neighbor. I'm your neighbor on Payne Road, a seasonal migrant. And I'm wondering, could you just tell me a little bit about what your thoughts are about, you know, preventive medicine and, you know, programs for the year-round residents or whatever. I know it's all been shut down with the COVID, you know, the exercise groups and things, but what are your thoughts about, you know, just improving our general level of health by preventive care, preventive medicine, our own efforts also? Thanks.
I think it's a great idea. I think it's a hallmark of certainly longitudinal care. I think the value we have on the island is we have so much to do outside. I think this is where our physical therapy program and also Allison's wellness program. Allison has many more hats now, but she's got an abbreviated schedule for wellness, whether it be for physical therapy to do like a home program or the wellness program to work on balance and lateral strength and confidence. Then they use that kind of training to go off and do things outside, get the fresh air, walk the trails. I think if somebody has felt that COVID has really made them a bit of maybe weak and maybe unstable, and then they feel less confident to go outside and do things, it's a great application of those processes. In our future, the building construction is actually built very much with group exercise programming in mind. So the entire downstairs of the addition is going to be built for group physical therapy, group exercise programming, working on health and strength training and lateral stability. So it's definitely in our future. You are right that it's all been abbreviated with COVID, but we have physical therapy and we have the wellness program if anybody needs right now. How are you, Ray?
I'm well, doctor, and my comment is, first of all, I want to thank you for taking some time in your day off to give us that required COVID test before we went on our vacation to the Virgin Islands. That was really nice of you. Anyway, but I also, my observation is listening to you today, I can see you. I think you came to us from the University of North Carolina, didn't you? Were you a teacher down there? You have exceptional talent for speaking clearly and getting your thoughts out to the community like you're doing today. So I was just really impressed with your presentation tonight. And I really think that this is a great program for you to continue. I think people will, like you said before, I don't know how many people you have in your audience there at the library, but or at the medical center, but so I'm just more of an ambassador now than I have been before because of this kind of presentation. So I want to thank you.
Oh, you're welcome. Thank you very much. And hopefully between our communications on YouTube and stuff that we put in print, that Lori and I and Allison have been able to kind of share with you some of our thoughts, that we're building a foundation for quality. We're building a foundation to allow people to age appropriately and safely in their homes here as long as they'd like to. It does take an infrastructure in order to do that. The town's been a partner in this as well, and we appreciate their support. I think a lot of people have been very generous to us, obviously with the virtual auction and whatnot. It's all done with a purpose. And I think we're starting to see that our relationship now with Rhode Island Primary Care Corporation and the Integra Accountable Care Organization will propel us to that more modern way of providing healthcare on the island. So that'll be really great. I think we're just in the midst of building what we are wanting to build, but it's exciting. So unless there's any other questions, I think we can, we're going to go talk at the town council meeting because we have today's open comment period for the budget. So we need to go and advocate for the medical center. But please, we're looking for constructive criticism. We're not perfect. We want to hear when we're not. And it's, I find it very important to know a specific, because I think it allows us to, probably a lot when you're doing your engineering, tell me what happened, and then I can reverse what probably should have happened versus a generality, because it probably speaks very much to a process problem that we have and a workflow gap that we need to work on versus kind of a general statement like, I can never get a hold of anybody. It's not a, we know that's not accurate, and it's also something that's not very helpful. It'd be like, what day, what time of day, because maybe there was an emergency. Maybe we knew that was happening, but we need to hear that. Okay, I think we're great. Thank you, everybody. Thanks for attending.